Hi, I'm Wendy Hodson. This is head trauma. Head trauma is important. There are 1.6 million patients with trauma annually in this country who make it to some sort of medical care facility. It's estimated that head trauma is 10% of healthcare costs in the United States. 70,000 people a year have lifelong debilitating loss of function. 50,000 people a year die. It's a leading cause of death in the young, and there are about 7,000 cases a year of post-traumatic epilepsy. The single most important thing in head trauma is to prevent it. In my former job, when the neurosurgical department had their residency review committee assessment, the first sentence in the reviewer's report was, "The resident who picked me up at the airport did not wear a seatbelt." Traumatic brain injury is relatively unimportant. It's the secondary and delayed effects that produce most of the devastating injury to the brain. The forces are largely dissipated by the soft tissues, by skull bending or fracture. This patient, for example, who clearly had a traumatic brain injury, the knife entered the skull, the right frontal bone. It grazed the bottom of the right frontal lobe. It crossed the midline anterior to the circle of Willis, and it crossed the left orbit superior to the optic nerve. So the only thing that happened to him after the knife was pulled out was an orbital hematoma from which he fully recovered. This person was shot, penetrating trauma to the left frontal bone, a band of hemorrhage along the deforming course of the energy of the bullet, with hemorrhage, intraventricular hemorrhage, subarachnoid hemorrhage. The bullet bounced off the inner table of the skull and ended up in the right parieto-occipital region. There was no injury to the rest of the brain outside the bullet tract, and this patient also had a remarkably good recovery. He was probably aided by the fact that his temporal lobe injury was in his non-dominant hemisphere, but he had a remarkably good outcome. Traumatic brain injury includes scalp and skull injury, extraaxial hemorrhage, brain laceration and hemorrhage, parenchymal contusion and hemorrhage, diffuse axonal injury, and choroid plexus hemorrhage. So this is a classic biconcave extraaxial hematoma. The cortex is displaced away from the inner table of the skull. The white matter is buckled, and this is a epidural hematoma. This patient has bilateral epidural hematomas as well as some small parenchymal contusions. Within the epidural hematoma, you can actually see the dura here peeled. Within the epidural hematoma on the left, there's these little black spots which tell us what? Pneumocephalus, which tells us what? Skull fracture, most probably where? Through the mastoid air cells, good, which was documented on other images. This is an unbelted driver who hit the roof of his car, hit his head on the roof of his car. On the CT, it is difficult to perceive, although if you're wide awake, you would be suspicious, I think, that there's some vague high attenuation at the top of the head. It's probably outside the brain. It's not subarachnoid. It's on both sides of the falx, but its precise relationship to the falx is unclear in this axial plane. Coronal CT would have worked, but he had a cervical injury, so MR was done instead. And it shows an extraaxial hematoma, which is displacing this structure, which is what? The superior sagittal sinus, so we know this is an epidural hematoma. You can also see the scalp injury. Okay, this is a 7-year-old who fell backwards while rollerblading. This hematoma is epidural. What are the clues that that's true? It does cross the midline. That's probably less important below the plane of the falx than it would be in the supratentorial compartment. What else? It's biconvex, so it's classic in shape for an epidural hematoma. There's little dots of air within it, like the other case. But most importantly, it crosses the tentorium, right? But here you see this vague sheet, band-like, partial volumed tentorium on each side. This is clearly the cerebral hemisphere because it's shaped like and has the gray-white pattern of the posterior temporal lobe. So, and the same on this side. So this component of the collection is supratentorial, this component is infratentorial, it crosses the tent. So just like the lesion that crossed the superior sagittal sinus, this too is an epidural collection. We don't think too much about subacute or chronic epidural hematomas, but they definitely occur. This patient does have a chronic subdural hematoma, but this is the dura. This is the hematoma in the epidural space that's kind of melting away from the margins, the way all hematomas do, like an ice cube melting from the periphery. So this component of the collection is in the epidural space, surgically proven. This one, in a patient who presented with seizures, we were not given a trauma history in this patient at all, has a extracellular methemoglobin, intracellular methemoglobin fluid level in this biconvex extraaxial occipital collection, which is also a surgically proven epidural hematoma. So they're not common, but they do occur. Epidural hematoma is not all that frequent. And, interestingly, it doesn't kill very many people. A small percentage of them are bilateral. Only half have the classic hit on the head, did fine, went down the tubes, or the classic lucid interval. Half of them don't. A reasonable percentage of them enlarge after diagnosis. Probably more of them would, except they are so commonly operated on acutely. About 90% are associated with skull fracture, meaning 10% are not. And most of them are associated with a vessel tear. Unlike the conventional treatment, the conventional wisdom, it's much more likely to be a sinus laceration or a middle meningeal vein laceration than a middle meningeal artery laceration. If you remember, you see the classic squamous temporal fracture crossing the middle meningeal groove. Well, the middle meningeal groove contains an artery and a vein, characteristically, and the vein is just easier to tear than the artery because it's thinner walled. Okay, here's a different lesion. We see this white stuff between the inner table of the skull and the surface of the brain in a patient with obvious soft tissue swelling of the scalp. There is a thin collection extending along the interhemispheric fissure anteriorly on the right, and a thicker collection extending along the interhemispheric fissure posteriorly on the right. There's a very little mass effect and no midline shift, probably because of the old volume loss in the occipital lobe that this patient had from a previous traumatic brain injury. So this is a characteristic of well, there is some subarachnoid hemorrhage in the cistern in the middle cerebral artery, that's true. But why is this not subarachnoid? Yeah, subdural hematoma, because it's not going into the individual cell size, so it's a subdural hematoma. This one is much harder to see, and even with subdural windows, it was still hard to see. What you can say is that there's apparent thickening of the calvarium. There's sort of fuzziness of the inner table of the skull on this side compared to this side. But what is much more helpful and I think more useful is the nature of the ventricular compression. You can see that the frontal horn of the right lateral ventricle is pushed back. The atrium and occipital horn of the right lateral ventricle is pushed forward. The body of the right lateral ventricle is pushed from its lateral surface, and the top of the lateral ventricle is pushed down out of the plane of, partway out of the plane of section, so it's partial volumed in a way that the contralateral ventricle is not. And really the only thing that ever does that, if you see this kind of ventricular deformity, it's a subdural hematoma until you prove it isn't, basically. Because something is surrounding the hemisphere on all its surfaces and kind of squishing the ventricle from all its directions. Obviously, if you had a mass here and a mass here and a mass here, you could have the same kind of ventricular compression, but probably would see the masses. Okay. The reason we couldn't see this collection on subdural windows is because this was a hemophiliac whose blood was not clotted, and so the blood, even no matter how we imaged it, the blood was isodense with the cerebral cortex. So this is a big subdural hematoma. So the child's fractures were corrected and he was operated upon. So this is a interhemispheric fissure subdural hematoma. They are relatively common. They are more common in non-accidental trauma, shaken baby or elderly, non-accidental trauma, but they occur in regular people as well. Here is another extraaxial hematoma at the vertex, apparently on both sides of the falx. And in fact, on coronal MR, it is on both sides of the falx, extending along the interhemispheric fissure bilaterally, and the superior sagittal sinus is normal in position. So this is bilateral subdural hematoma that at first blush appears to cross the midline, but in fact it's bilateral subdural hematomas, and they might not even be the same age because they don't have exactly the same signal characteristics on MR. How are these two cases different? Or how are they the same? Either one. So these patients both have subdural hematomas layering along the tentorium, but they are different in what way? Exactly. So this one is a neonate with a subdural hematoma along the left tentorial leaf that is causing hydrocephalus. On other images, there was fourth ventricular and cerebellar compression. So this is a subtentorial temporal subdural hematoma, tentorial subdural hematoma. This one has mass effect on the atrium of the occipital horn, which is compressed. And you can see that the gray matter of the occipital lobe is displaced away from the expected location of the tentorium, which is here on the other side. Okay, so this is a tentorial, supratentorial subdural hematoma. The surgeons like to know which side of the tent it's on. We also all know that the density of blood evolves over time. On average, it becomes isodense with gray matter when it's been there for 3 weeks, but there are many, many things that can change that. The most common, I think, and certainly the most obvious, is repeated bleeding within a subdural collection, which is occasionally due to repeated trauma, but much more often due to the fact that as subdural hematomas evolve, they develop membranes. The membranes have neovessels in them, fibrous tissue with new vessel formation, and they are very friable, and rebleeding is easy to instigate. So that the evolution of blood over time is difficult to time. On average, it's 3 weeks. So this is a unilateral isodense subdural hematoma. It is easy to see because the central white matter of the cerebral hemisphere is buckled. On the normal side, you see the central white matter of each individual gyrus coming out into its gyrus and approaching within a few millimeters to the inner table of the skull. Whereas here, none of those subarcuate U fibers get much closer to the skull than about 2 centimeters. So either there has to be an isodense extraaxial collection here, which is far and away the probable thing, or the cerebral cortex has to be somehow uniformly thickened by something which is isodense with it, and it's pretty hard to think of anything that could possibly do that. As blood continues to evolve over time, it of course liquefies, so you may develop a fluid-fluid level where the crenated cells sediment, leaving the supernatant fluid with a slightly differential density. So posteriorly, this subdural is isodense with cortex, but anteriorly it is slightly hypodense and therefore much easier to see as being different from the cortex. And you can see the cortex displaced. This subdural hematoma is entirely low attenuation in comparison to gray matter, and again, therefore much easier to see. We were unable to get more than one history of trauma in this patient, which preceded the imaging study by about 6 weeks. But people with subdurals are often confused, so it's possible he didn't remember. This is a CT scan in a patient with severe headache after trauma. Pre-contrast, post-contrast, regardless of the windows on the CT, we were unable to identify anything abnormal, but the doctors knew her well and believed her, so we did an MR. These 2 studies were done the same day. And this is a subacute subdural hematoma, extracellular methemoglobin, and it is obviously present on MR. So although CT is the test of choice for acute traumatic brain injury, it's quick, it's cheap, it's available 24/7 almost everywhere, and it's very sensitive for acute intracranial hemorrhage under most circumstances. If your index of suspicion is high enough, or if you know you're worried about a subacute brain injury, MR is probably the test of choice. We tend to think of epidural hematomas as being the ones that are football-shaped, but subdural hematomas, as they evolve over time, can change in shape. This one has developed enhancing membranes. See? Right? It is biconcave. It is pushing the brain away. There's a lot of mass effect and shift, and this is a surgically proven subdural hematoma. Occasionally, they develop really weird shapes and develop septations. This, too, is a surgically proven subdural hematoma in a patient who presented with seizures. Subdural hematomas are relatively more common than epidural hematomas. I was flabbergasted when I first learned how devastating they are. Depending on your series, more than 50% of patients with acute subdural hematoma will die. 15% of them are bilateral. And they are particularly common in child abuse and elderly abuse or elderly falls. What's this? Good. So the patient has a scalp injury. There is obvious step-off of the skull, which would, of course, be easier to see with bone windows. There's pneumocephalus. So this is an open, depressed skull fracture with an underlying parenchymal contusion. It took me 3 years to find this slide for a medical student lecture I was putting together. It is remarkably uncommon to see a parenchymal contusion immediately deep to a fracture. I don't have any idea why, but it took me 3 years to find this case. Cortical contusions are almost half of traumatic brain injuries. Shearing forces are also important here. But many of them are due to direct brain trauma, either the primary injury or the so-called contre-coup injury, where the brain bonks up again the other side of the head. However, it's going out of fashion that the brain hitting the skull is really the cause of contusion, and it is believed now by most that contusions are also due to shearing injury. However, the things that we call contusions look different from the things we call white matter shearing injury. They have a different distribution and they have a different outcome, better than shearing injury. So they don't seem to be quite the same. So here is a patient who stuck his head out wondering why the subway wasn't coming and was hit in the face by a train. He had massive swelling, multiple facial fractures, pneumocephalus. The parenchymal hemorrhage is quite obvious in the left frontal lobe. The edema and swelling is more obvious in the right frontal lobe. I think brain contusion is just like hitting your arm with a baseball bat. You know, sometimes it's just edema. Sometimes you get a goose egg, which is pure hematoma, and most of the time you get swelling and discoloration, which is a mixture of edema and hemorrhage. And the proportions are difficult to predict. Over just a few hours, this patient's hemorrhage increased massively, especially on the left, but the hemorrhage on the right also became more obvious. The mass effect on the ventricles became more obvious, and he had to have a partial lobectomy. This is a patient who fell backwards while skateboarding. He had a linear left occipital fracture. He had an inferior cerebellar contusion at the plane of the fracture, which was not depressed, sorry. And he had bifrontal contusions, which would often be called contre-coup. Left cerebellum, right frontal, those were his only parenchymal brain injuries. So cortical contusions occur in relatively predictable locations. They are most common in the temporal lobe, where they are most common in the poles of the temporal lobe and in the inferior surface of the temporal lobe, an area that CT isn't so good for sometimes. But they can occur on the convexity surface of the temporal lobe as well. They are almost as common in the frontal lobe, again, most common in the frontal poles and the inferior surface of the frontal lobes, but they can also occur on the convexity surface. They are not uncommon in a parasagittal distribution, lateral to the falx, and don't forget that they can occur in the inferior cerebellum, again, an area for which CT is sometimes not good due to streak artifact. Okay, new topic. So this patient's CT was either normal or questionably abnormal, based on the MR done just an hour and a half or so later, where there is an obvious parenchymal T2 hyperintensity. Maybe you can hallucinate that there's vague low density in the brain parenchyma, and maybe this is a tiny contusion, but it could just be partial voluming with the gyrus. So normal or nearly normal CT, obvious lesion on the MRI, Glasgow Coma Scale of 5. So what is this? Shearing injury. White matter shearing injury, also known as diffuse axonal injury. Here's another patient with the same clinical story. He was terrible at the time of the first scan and remained terrible, but no worse in his clinical status 24 hours later. On the first scan, all we see is a single punctate focus of hemorrhage at the gray-white junction in the frontal-parietal region. 1 day later, this is already starting to fade because it's so small, but other areas of parenchymal hemorrhage are now evident, and there is extensive low attenuation in the white matter, a little bit in the cortex as well, and this patient also has diffuse axonal injury. Diffuse axonal injury occurs in almost half of traumatic brain injuries. It is predominantly due to acceleration, deceleration, and rotational injuries within the skull. The gray matter and the white matter have slightly different physical densities, so they can move on each other and produce shearing of axons, shearing of capillaries. It is a diffuse brain injury. Imaging, even MR, demonstrates only focal lesions and is just the tip of the iceberg of what has happened to the patient's brain. The classic DAI is the CT looks normal or nearly normal, and the patient looks dreadful. The most common location of shearing injury is at the gray-white junction of the cerebral hemispheres. The corpus callosum is frequently involved, especially the splenium. Periventricular white matter involvement is common, and involvement of the hippocampus, producing memory dysfunction, the cerebral peduncles, producing motor dysfunction, the superior colliculi, producing vision problems, and the reticular formation, producing alterations of consciousness, are also common. On MR, acutely, FLAIR is one of the better imaging studies. Here, for example, is DAI in the splenium of the corpus callosum. We see the excess water, so increased FLAIR intensity compared to normal brain. There are some more subtle lesions elsewhere in the brain. On delayed imaging, gradient echo T2 is a better test because you see the susceptibility artifact. Here is a lesion, again, in the splenium of the corpus callosum with subcortical old hemorrhages at the gray-white junction in the frontal lobes in this example. The patient also has very big sulci and very, very big ventricles, which he did not have on admission. So he had severe cerebral volume loss about a month after his trauma. Another piece of evidence, I think, that this is a diffuse brain injury, even though the focal lesions that we have demonstrated are only a very small amount of the brain. Some have suggested that diffusion-weighted imaging is very sensitive in acute axonal injury. This is certainly an example where it's pretty true. The images on the DWI, the lesions on the DWI are more obvious, they are larger, they are more extensive than on the FLAIR or the T2 or the gradient echo images. These authors suggest not only that DWI imaging is very sensitive, but also that it is a better prognosticator for ultimate outcome than the conventional sequences on MR in traumatic brain injury with DWI. Diffuse axonal injuries can be seen in mild traumatic brain injury. defined in this paper by a Glasgow Coma scale of 13 or better. 15 is the best you can have. And they may be demonstrated by MR in up to 30% of mild traumatic brain injuries if the patient has post-concussion syndrome. That seems high to me. I mean, I've been involved in Dr. Grossman's brain trauma serial imaging study, and I've seen quite a large number of delayed images in these patients. And I haven't seen this percentage, so I think it depends on what your subpopulation is. But okay, new topic. What do you see here? Okay, so on the right, there is a large, moderately large hemorrhage that involves the lentiform nucleus, kind of grazes the back of the head of the caudate nucleus, involves the anterior aspect of the thalamus, and extends into the third ventricle. We spent a lot of time staring at this. The anterior part of it is obviously calcification, but the posterior part of it does not measure high enough to provably demonstrate basal ganglion calcification, even though it's located in the globus pallidus, which is the commonest site. But just to put you out of your impatience, we followed this patient for a period of about 2 months, and this lesion evolved like a hemorrhage always evolves, and this lesion remained completely stable for 2 months. So this patient has a unilateral basal ganglion hemorrhage after trauma. Patient's 18 years old, has normal blood pressure, had a normal angiogram, so does not have an underlying aneurysm or vascular malformation, has no coagulopathy or any other explanation for intracranial hemorrhage, and was the passenger in a high-speed motor vehicle accident. So we have to conclude that this is a traumatic basal ganglion hemorrhage. They are not common, but they do occur. Here is another patient with this hemorrhage is in the midbrain. This was the only intracranial hemorrhage in this patient, who was also in a high-speed motor vehicle accident. So these are deep cerebral gray matter or brainstem traumatic brain injuries. The literature says 5 to 10% of major traumatic brain injuries have these lesions, and I believe it. The last 2 cases are unusual, though, in that they were isolated hemorrhages with no other evidence. We see these often in patients whose brains are totally smashed, but not so often in people as the only traumatic intracranial injury. Nevertheless, they do occur. Probably they are in some way related to shearing injury. Where is this hemorrhage? Good. So there's a small focus of, this was isolated only in this location. It's clearly behind the colliculus and anterior to the cerebellum within the subarachnoid space. Different patient had isolated subarachnoid hemorrhage in the Sylvian fissure on the left. And these are both examples of isolated traumatic subarachnoid hemorrhage. Subarachnoid hemorrhage occurs in 11% of traumatic brain injury. If it is isolated, it has little impact on the clinical outcome. It does not seem to have the delayed effects like vasospasm and infarction that we see in aneurysmal subarachnoid hemorrhage. And it is most commonly seen at the site of impact, although these 2 cases I just showed you are exceptions. Okay. Where's this blood? The occipital horn of the lateral ventricle. Intraventricular hemorrhage secondary to trauma can be dependent in, free in the CSF, and therefore is usually dependent, often in the occipital horns. It can also occur within the choroid plexus, and then sometimes it's kind of lobulated and looks intrachoroidal. Either can occur. Intraventricular or choroidal plexus hemorrhage is not common as an isolated finding. It is more common in association with other findings of traumatic brain injury, especially axonal injury. When there is no other evidence of brain injury, the outcome is good, although a percentage, maybe as high as 10%, develop hydrocephalus that requires shunting. In terms of outcome, secondary traumatic brain injury is believed by most people to be more important than the primary injury. That would include things like herniation, hypoxia, infarction, delayed hemorrhage, diabetes insipidus. Okay, so this acute subdural hematoma isn't very thick, but it was very extensive. It was along the tentorium, under the temporal lobe, over the cerebral convexity, all the way up to the top of the head, extending into the interhemispheric fissure, both posteriorly and anteriorly, although I haven't shown that. So a very, very big, although thin, subdural hematoma. This patient's probably not going to do very well after this subdural hematoma is evacuated. How do we know that? Because he's herniating, okay? His suprasellar cistern is completely effaced. His midbrain is markedly distorted. What's this little thing? That's the right temporal horn. And when you remember that the right temporal horn has temporal lobe medial to it, if the right temporal horn is behind the dorsum sella, then this patient's temporal lobe is reaching the midline. So massive herniation, marked midbrain compression. And what's this? White line? Midbrain hemorrhage, called Durée hemorrhage, which is probably due to the fact that when you have transtentorial herniation, the midbrain gets squashed from one or both sides, but it's easier with my hands to say both sides, which causes the midbrain to elongate. And the perfusion to the midbrain is from penetrating arterioles from the basilar artery that run from front to back within the midbrain. So as the midbrain is stretched, those arterioles are elongated and they just blow. Okay, the other finding here, which is extremely subtle, but you can make it if you're really awake, is in the right occipital pole compared to the left occipital pole, there's subtle loss of gray-white discrimination. A few hours later, after the subdural had been evacuated, he no longer has mass effect and midline shift. He's developed massive hydrocephalus. His midbrain hemorrhage has extended up into his left thalamus, and the loss of gray-white discrimination is becoming more and more obvious, right? Loss of gray-white discrimination in the inferior temporal lobe, extending back into the occipital lobe, and this is secondary to posterior cerebral artery infarction, secondary to herniation. That's right. So transtentorial herniation, the uncus and the parahippocampal gyrus first slide medially, and then when they reach the free edge of the tentorium, they slide down in the tentorial incisura between the midbrain and the free edge of the tent. Because the posterior cerebral artery lives in that space, the temporal lobe pushes it down through the tentorial incisura. Because the posterior cerebral artery is attached to the cerebral hemisphere at its periphery, it has to come back up over the free edge of the tentorium to perfuse the supratentorial brain, and it gets pinched off at the tentorial incisura, producing occlusion. The penetrating vessels of the midbrain are stretched, which may produce Durée hemorrhages. The third nerve is compressed, producing blown pupil. The cerebral peduncle is compressed, producing contralateral hemiparesis. So that's transtentorial herniation. This is the same patient, again post-op. This time we see this area of loss of gray-white discrimination along the mesial aspect of the frontal lobe. What's this? Anterior cerebral artery infarction, secondary to? Possibly. Subfalcine herniation. Good. So in subfalcine herniation, the brain tries to cross the midline, but the falx stops it. However, below the free edge of the falx, above the corpus callosum, the cingulate gyrus can push its way across the midline. As it pushes its way across the midline, it pushes the anterior cerebral artery with it. The ipsilateral anterior cerebral artery, either the callosal marginal or the pericallosal artery, either one or both, can get pinched off against the free edge of the falx, producing ACA territorial infarction. The contralateral anterior cerebral artery, of course, is just pushed further away from the midline than it already was, and contralateral ACA infarction would not be expected to happen secondary to infarction. PCA territorial infarction can be on the same side as the mass, it can be on the opposite side of the mass, or it can be on both sides, whereas ACA infarction secondary to herniation is always ipsilateral to the mass. This one's not post-traumatic, but it's the best example I had. Of course, you can have anoxia after trauma due to cardiac injury, due to thoracic injury, due to strangulation. This person just stopped breathing. But this is the classic appearance of acute anoxia. We still have well-defined gray-white discrimination. You can see the cortex as clearly and unequivocally separate, different from the white matter, both in the basal ganglia and in the cerebral cortex, but their densities are reversed, the so-called reversal sign. Because the metabolic needs of the gray matter are greater than the metabolic needs of the white matter, they become dysfunctional first. This is a transient phenomenon on imaging because, of course, if the cell body lives in the gray matter and its axon lives in the white matter, it's just a matter of time before they're both abnormal. This is an unfortunate patient that I want to say was not seen at NYU. He came in with trauma, except for an old traumatic occipital injury in the right side. This scan was read at the time and in retrospect as normal, period, normal. Unfortunately, the ER got busy, and they kind of ignored him for a little bit too long until he was found decerebrate. So this is a very striking example of delayed subdural hemorrhage. Presumably, he had a few red cells in his subdural space at the time of the first scan, but we couldn't see them. There weren't enough of them. Delayed subdural hemorrhage virtually always occurs within 6 hours. So if you are among those who believe that it is wise to do a second CT in all trauma patients before they're sent home from the emergency room when the first scan is normal, I myself am not enthusiastic about that, but I know some people think it's a good idea. Probably 6 hours is the optimum time to do the second scan if the patient is doing well, obviously earlier if he's not. This is a not very good example of diffuse cerebral edema. Most of these patients are really sick and they often don't get imaged, but if you look at the right side of the head, compare it to the left, there is some subarachnoid hemorrhage, but more pertinently, there is diffuse low density involving basically the entire right cerebral hemisphere. Anteriorly, it seems to involve predominantly the white matter. Posteriorly, it seems to involve both the white matter and the gray matter. There's mass effect and midline shift, and this is unilateral cerebral edema. Cerebral edema, of course, is massive increase in brain water with associated increased intracranial pressure. It is more common in children than adults after trauma. It is seen frequently in severe traumatic brain injury, rarely in isolation. It's a very bad thing to have. It's not a particularly easy diagnosis to make with confidence in view of all the other things these people have going on in their brains at the same time. This is a patient who also has obvious low attenuation in the right cerebral hemisphere with massive mass effect on the right lateral ventricle and midline shift. Most of the lesion seems to involve both the gray matter and the white matter. Some of the right cerebral hemisphere is spared, particularly the right frontal operculum and the occipital lobe. And what's this due to? Okay. He was shot. And he was shot where and what happened? Right. He has a traumatic carotid occlusion secondary to a bullet, which was in the foramen lacerum. One of the classics boards question, what goes through the foramen lacerum? Answer, nothing important. But over the foramen lacerum runs the precavernous segment of the internal carotid artery. So this patient was shot right in the foramen lacerum and occluded his right internal carotid artery. Entry wound was down here someplace. This patient came into our institution at the time of the angiogram. He was admitted to the head and neck service for intermittent epistaxis. no one elicited the history that he'd been at another hospital 6 months before after a traumatic brain injury, where he'd been in the intensive care unit for some period of weeks. I got this image from that institution. He had a skull base fracture traversing the right carotid canal. At the time of his acute injury, he had some fluid in his sinuses, et cetera, et cetera. So he had a skull base fracture which put the right carotid artery at risk. He was admitted for elective workup of epistaxis when he developed an exsanguinating arterial hemorrhage from his nose. At midnight, he had an emergency arteriogram. These hemostats are related to his packing because he was bleeding like I've never seen. This is an injection into the right internal carotid artery. As you come up past at the level of the posterior cavernous carotid artery, there's this triangular outpoaching of contrast, and this is what? This is a traumatic pseudoaneurysm that, because he was bleeding so much and because he had a patent circle of Willis, they just embolized his internal carotid artery, proximal and distal to the pseudoaneurysm. Unfortunately, by then he had massive anoxic brain injury, unfortunately. Okay, this patient was stabbed, but with what? Using what? This is a comb. It's a comb that was filed to a point. This patient was a prison guard, stabbed by one of the prisoners into the right orbit, through the superior orbital fissure, and into the temporal lobe. There was a large parenchymal hematoma, which was better seen on other images, but you can see that it's there. And he had an angiogram and has a small traumatic pseudoaneurysm of the temporal branch of the middle cerebral artery. This is also a trauma patient. What do you see? You can tell we're on the vascular injury part of the talk here, so what do you see? That would be a good interpretation, but in this case, incorrect. What you do see is that this area is very void of vessels. This is a late arterial phase, so you're seeing brain staining of the midbrain, of the brainstem and the superior aspect of the cerebellum, as well as the occipital lobe, but there is no brain staining here in the inferior cerebellum. So that's a good observation, but an incorrect interpretation. What else do you see? Okay, what do you think of the vertebral artery in comparison to the basilar artery?
Dissection.
Good. So the vertebral artery is abnormally dilated. It's big, and then it gets a little smaller, then it gets big, and then it gets a little smaller. And this is the pica, posterior inferior cerebellar artery, which is occluded. So this is failure to perfuse the pica territory secondary to the pica occlusion. Whether this was a transection and this a dissection, or this was a dissection and this an embolus, is a little bit difficult to verify. I favor the latter because this was closed rather than open trauma. So, but whatever, he has a vertebral artery dissection and a pica occlusion. So primary vascular injury and traumatic brain injury includes arterial injuries, which include transection, occlusion, laceration, dissection, pseudoaneurysm, intimal injury, which can produce an intimal flap, thrombus, and distal embolization and infarction, and traumatic arteriovenous fistula. Venous injuries include sinus occlusion, sinus laceration, which often presents with an epidural hematoma, cortical vein occlusion, which I've never seen, but it must occur, and cortical vein laceration, which typically presents with subdural hemorrhage because the cortical veins are stuck to the brain at one side and stuck to the sinus at the other side, and when they are injured, they typically bleed into the subdural space. So MR is better than CT when this is suspected. So what is this? We see enlargement of the subarachnoid space bilaterally. We see bilateral subdural collections of different signal characteristics, suggesting that they may be of different age. And we see bilateral cortical parenchymal contusions in both frontal lobes, and maybe a little bit of subarachnoid hemorrhage. So what is this? Non-accidental trauma, okay. So non-accidental trauma, which we typically think of as child abuse, we have to remember that it also occurs in the elderly population, as well as other disabled populations. The most common finding is subdural hemorrhage. Classically, the subdural hematomas are of more than one age. They can even be of multiple ages on one side. We talked about how it can be difficult on imaging, however, to be completely sure that subdurals are of different ages rather than just evolving differently. In shaken baby syndrome, they are classically in the posterior interhemispheric fissure. Cortical contusions are common. Shearing injuries are common. Cerebral ischemia and infarction can occur. Unexplained fractures, of course, in the head or anywhere else. And retinal hemorrhages. I think only once have I actually seen retinal hemorrhages on imaging, but our clinical colleagues can certainly see them. Child abuse. It is estimated that more than 95% of life-threatening head injury in infants is due to abuse. Most abused children have serious neurologic sequelae. Direct impact, shaking, asphyxia, and starvation are also all part of the syndrome. Diffusion-weighted abnormalities were first described in traumatic brain injury in children and may occur in up to 90% of pediatric non-accidental trauma. So this is a patient whose injury was not particularly huge, but was in a very unfortunate location. What do you see?
The history.
I beg your pardon?
What's the history?
A competitive water skier who landed on his face at 70 miles an hour. This was sent to me by one of my residents because she knows I lecture on head trauma. Any of my other former residents who ever want to send me a good case, I'm very grateful. So there is abnormal increased T2 signal in the medulla, okay, which could be a lot of things, but in this context, there is separation of the clivus from the odontoid, right? That's about almost 2 centimeters of separation. Usually they're within a few millimeters of each other. There is abnormal gray stuff in that space. Usually that space is filled with fat. This is fat, but this is not. There's prevertebral soft tissue swelling. And a lot of this stuff, which is kind of gray on T1, is black on T2, compatible with acute hemorrhage. So this patient has a craniocervical disassociation with tear of the ligaments that attach the clivus to the odontoid process. And he had an extension injury with a medullary contusion. Probably the only reason he made it, this is where you breathe and control your heart rate and stuff, so probably the only reason that he made it to the hospital was because this occurred in competition. He was instantly pulled out of the water and instantly intubated, otherwise he probably would have died at the scene, and in fact he only survived for about 2 days. So mild traumatic brain injury is the vast majority of traumatic brain injuries. Standard CT and MR are almost always normal, although diffusion-weighted images may be abnormal in up to 30% of these patients. Neuropsychological impairment is common: cognition, memory, just feeling, out-of-body feeling, that kind of stuff, chronic headaches. Most patients, but not quite all, recover after usually months. In mild traumatic brain injury, on the less conventional sequences, we can see diminished perfusion regionally. We can see abnormal NAA creatine ratios in the white matter and the corpus callosum, and possibly, this research is ongoing, diminution in whole brain NAA, which is a neuronal marker. With PET scanning, focal hypometabolism can be seen. With functional MRI, persistent changes in activation patterns on standard memory tasks can occur. And each of these non-invasive things may show more widespread abnormality than the anatomic images do, and they may show better correlation with outcomes than the anatomic images may. What we can do with this information from a practical standpoint is less clear to me, but knowledge of prognosis is certainly not without value. CT, as we all know, is used to direct the immediate surgical and/or medical management of acute traumatic brain injury. MR may be more relevant in terms of explaining the neurological deficits and predicting recovery.